good evening and good afternoon to our speakers, chairs, and audiences of ACNS webinars in various parts of the world. We are here again with two new wonderful speakers who would be giving us very insightful lectures ahead. The first speaker for today is one of the most famous faces of British neurosurgery, Professor Peter Hatchison. He is an NIHR research professor and head of Division of Academic Neurosurgery within the Department of Clinical Neuroscience, University of Cambridge. He holds an honorary consultant neurosurgeon post at the Edinburgh Hospital. He is also the director of clinical studies at the Robinson College, Cambridge. He is the president of Clinical Neuroscience section of the Royal Society of Medicine, Royal College of Surgeons, Neurosurgical Specialties, lead for clinical trials, chair of the academic committee of the Society of British Neurological Surgeons, secretary of the European Association of Neurosurgical Societies, and trustee of the International Neurotrauma Society. He is also the chair of the Neurotraumatology Committee of the WFNS. Professor Hatchison's research subspecialty interest is in the management of neurotrauma, specifically head and traumatic brain injuries. His research interest in acute brain injury involves utilizing multimodality monitoring technology, which is measurement of pressure, oxygenation, and chemistry to increase understanding of the pathophysiology of brain injury. He is also the lead investigator for the International Rescue ICP study evaluating the role of decompressive craniectomy in traumatic brain injury, as well as the ongoing global neurotrauma outcome study and the Genospine study. He has co-authored over 200 publications, including the Lancet and Brain, and has been a lead applicant in over £6 million of grants. He is the joint editor of the book Head Injury, a Multidisciplinary Approach. We are extremely honored and thankful to Professor Hatchison for accepting our invitation to be a speaker at our webinars. Today he is going to talk about rescuing the injured brain. The second speaker for today is our honored guest from China, Professor Bing Zhao. Professor Zhao is the Associate Professor of Neurosurgery, Wenji Hospital School of Medicine, Shanghai Jiatang University. He has more than 60 peer-reviewed publications and is the author of 5 books. His main areas of clinical practice and research involve surgical and endovascular treatment of cerebrovascular disease, including hemorrhagic and ischemic stroke. We are so thankful to Professor Bing Zhao for accepting our invitation to be a speaker at our webinars. And today is going to talk about intravascular recanalization of non-acute vertebrobasilar artery occlusion. The chair for the first session of today is our honored guest from Pakistan, Professor Tariq Khan. Professor Khan is the Dean of the Northwest School of Medicine located in Peshawar, Pakistan. And he's a professor and head of the Department of Neurosurgery at Northwest General Hospital and Research Center. And Dr. Khan is the chairman of the Neurotraumatology Committee of the WFNS, and is also the chairman of the Alliance Healthcare Private Limited, Pakistan. Dr. Khan is a member of Neurotrauma Committee and the faculty of Asia-Australia Society of Neurological Surgeons, as well as Medical and Dental Academic Board, Pakistan. He is a convener for Neurotrauma Committee. He is also the Dean of Faculty and examiner for the Neurosurgery College of Physicians and Surgeons of Pakistan. Previously, Dr. Khan served as the president of the Pakistan Society of Neurosurgeons. We are extremely honored and thankful to Professor Tariq Khan for accepting our invitation to chair today's first session of webinars. The second chair for today is one of the most famous hybrid surgeons of the world, Professor Shu Bin. Professor Bin is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. Professor Bin's practice include hybrid neurosurgery, and he also has the most number of bypass surgeries in the world for myomas disease. Professor Bin's contribution to ACNS webinars has been outstanding. We are very much indebted to him for that. We are extremely thankful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual platform to Professor Tariq Khan.
Professor Peter Hatchison will going to talk on this very important subject of rescuing the injured brain. Professor Hatchison, please.
Thank you very much, Tariq. Colleagues, and thank you for the invitation to present at this webinar. So as Tariq said, I'm going to talk about rescuing the injured brain and focus on predominantly decompressive craniectomy as an operation of which there is controversy but increasing interest in the management of patients with traumatic brain injury. The management of these patients is often complicated along the pathway from the scene of an accident through hospital care, rehabilitation, integration in the community. But there's been a lot of interest in the operative management of these patients in terms of indications for surgery. And that arises because the major problem that these patients face following traumatic brain injury is that of increased intracranial pressure, which affects cerebral blood flow, oxygen delivery, and energy failure, resulting in further brain swelling. And treatment is therefore geared at controlling intracranial pressure. And we have a target for intracranial pressure of 25 millimeters of mercury. And that is achieved by a number of different interventions, a combination of medical and surgical measures. And the medical measures include intubation and ventilation. With sedation, we use propofol, analgesia, fentanyl, atracurium as a muscle relaxant, nursing patients head up, controlling their blood gases, the use at stage 2 of ventriculostomies to drain CSF to control pressure, in stage 3 to increase the blood pressure and augment the cerebral perfusion pressure. There is the option for hypothermia, although also controversial, but our particular interest was in those patients whose intracranial pressure was difficult to control, remain raised and refractory, and in these patients there is the option for barbiturate coma with thiopentone or a decompressive craniectomy. What do we mean by a decompressive craniectomy? This operation involves removal of a large part of the skull. It can either be a unilateral hemicraniectomy or a bilateral bifrontal craniectomy. It has been around for several decades and has been indicated when the treatment of intracranial pressure has not been successful with other treatments. We know it removes part of the skull, and it is clear now through various studies that it also involves opening of the dura. But the concerns are that does it actually help lower the intracranial pressure, and do the results justify the treatment? It may be an unnecessary procedure in patients deemed to have a good prognosis, but of greater concern is the poor prognosis patients who may move from mortality, a life saved, but into states of very severe disability. And there are also a number of complications associated with this procedure. It was actually described over 100 years ago now by Cocker: if no CSF pressure but brain pressure exists, then pressure relief must be achieved by opening the skull. And it has been in and out of fashion since then. And we felt that there needed to be some better evidence as to both the benefit and safety of this operation. In the context of trauma, it can be performed as a primary procedure, that is a primary decompressive craniectomy. Here we have a patient with an acute subdural hematoma. We would agree this patient needs an operation. The bone flap is elevated, the dura is opened, the hematoma is evacuated. The question then is, do you replace the bone flap back at the end of that operation, or do you leave the bone flap out? Leaving the bone flap out is a primary decompressive craniectomy. This operation can also be performed as a secondary procedure several hours or often days after the injury when other treatment has failed to control pressure, and this secondary decompressive craniectomy is largely addressing the diffusely swollen brain. What about surgical technique? So the unilateral decompressive craniectomy for primary decompression is a large trauma craniotomy, the classic question mark flap. We know the bone flap must be of 12 centimeters in diameter. We know that the dura needs to be widely opened, the brain decompressed, and the dura can either be left open or closed with a wide, non-constricting duroplasty. In terms of tips for the surgical technique for hemicraniectomy, positioning is critical. You must make a large bone flap. We tend to be conservative in the management of contusions and tend to leave the brain parenchyma itself intact unless there is a contusion that is actively bleeding near the surface. Please preserve the bridging veins, and we tend to close with surgical and non-suction drain. The bifrontal decompressive craniectomy we reserve for secondary decompression in diffuse injury, a bicoronal incision, we take the bone flap back to the coronal suture, down to the floor of the anterior cranial fossa with a perional extension. You can see there the dura exposed. The dural opening is a U-shaped opening based on the superior sagittal sinus, and our preference is to divide the falx at its most anterior extent. And this shows the procedure by which we divide the falx through two sutures, the division of the falx. And if you do that, that is the cut edge of the falx, you get a very nice decompression and avoid issues with brain herniation. It is also important to consider the frontal air sinuses, and we try and avoid opening them. If they are open, they need to be appropriately repaired, and the best way to manage that is to take the pericranium as a separate flap. On breaching the sinus, it can be appropriately repaired using this pericranial flap. It's important when undertaking the bilateral craniectomy to leave a generous margin between the scalp incision and the craniotomy, the bone incision posteriorly. If you do that, you will make the cranioplasty operation, the subsequent reconstruction, much easier. If that margin is too small, when the scalp sinks, you will find the scalp incision is over the brain, and this makes the cranioplasty operation unnecessarily difficult. As I've said, consider the anatomy of the frontal sinus on the CT, divide the falx at its anterior extent. We have undertaken a number of computational modelling exercises, a collaboration with the University of Cambridge Engineering Department, where we are trying to model the best size and location of craniectomy. We know that if the craniectomy is too small, we can end up with stress on the brain margins. We have undertaken a study to look at the different area gained from a bifrontal versus a unilateral craniectomy, and the volume gained is very similar between the two. However, there appears to be less herniation and less brain displacement through the defect with a bifrontal craniectomy than a unilateral. For diffuse brain injury, we advocate the bifrontal procedure as opposed to a hemicraniectomy. What we're also learning is that whilst it is effective at lowering intracranial pressure in many patients, there are others whose intracranial pressure remains raised following a decompressive craniectomy. It's important to undertake post-operative CT scanning. If it is purely brain edema, we look at sedation, ventilation, osmolotherapy. There may be an evolution of mass lesion requiring further surgery. Maintain good arterial flow with inotropes. Some patients will require an external ventricular drain following their decompression, but we're beginning to learn that many of these patients have refractory intracranial hypertension because their venous outflow is obstructed. So we would advocate in these patients post-operatively, if their pressure remains high, as well as undertaking a plain CT scan, to add to that a CT venogram. And you can see a patient here who has diffuse narrowing of the right transverse sinus secondary to thrombosis following a decompressive craniectomy. Of course, if you undertake a craniectomy, you will then need to reconstruct the skull. This operation, cranioplasty, there are controversies in terms of the timing and the material of cranioplasty. Our current preference is to use titanium to reconstruct the skull, but there are issues in terms of the management of hydrocephalus, concerns in relation to infection, seizures, and cosmesis. Perhaps we could pick up some of the issues around cranioplasty in the discussion. So if we return to our protocol for the management of patients at stage 5, the use of barbiturate, coma, thiopentone, and decompressive craniectomy is controversial, and that has been the subject, therefore, of a number of surgical trials. There are surgical trials considering a number of different pathologies that we see following traumatic brain injury, including intracerebral hematoma, the Stitch studies, diffuse brain injury, rescue ICP and DECRA, acute subdural, rescue acute subdural, and trials in chronic subdural hematoma. In the context of decompressive craniectomy, there are now 3 major international randomized trials. For secondary decompressive craniectomy, we have the DECRA trial and rescue ICP, and for the primary decompressive craniectomy, the rescue acute subdural. The DECRA study sought to determine the role of decompressive craniectomy as an early procedure within 72 hours of diffuse injury with an ICP threshold of 20 millimeters of mercury for 15 minutes, and was run by Jamie Cooper and Jeff Rosenfeld from Australia. What I'm going to do, I'm sure many of you are familiar with the results of both DECRA and rescue ICP, so I will summarize them, but spend the majority of the remainder of the talk looking at the results and how we are interpreting them to change practice. So in summary, DECRA showed no difference in mortality between those randomized to decompressive craniectomy versus standard care, whereas a higher rate of unfavorable outcome in those allocated in the decompressive craniectomy arm. Interestingly, when you look at the ICP tracings of DECRA, you can see that decompressive craniectomy led to better control of ICP than those randomized to standard care. But actually, the ICP control was good, even in the standard care, significantly below our threshold of 25 millimeters of mercury for rescue ICP. Rescue ICP was a multi-center trial of decompressive craniectomy for traumatic intracranial hypertension. It sought to address the hypothesis that this operation can improve outcome as a last tier rescue therapy for refractory post-traumatic intracranial hypertension. We sought to randomize patients with a traumatic brain injury on a ventilator, ICP measured. ICP was high and not controlled at stage 5 of our treatment protocol, and we randomized them into advanced medical management, i.e. barbiturates, versus surgical management of a decompressive craniectomy. We included patients with TBI requiring ICP monitoring. Our ICP threshold was different to DECRA. It was more than 25 for a period of 1 to 12 hours with an age range of 10 to 65 years. Patients were admitted to the ITU, treated initially with intubation, ventilation, sedation, monitoring. If their pressure was high, they went to stage 2, where we tried ventriculostomy, inotropes, and other medical therapies to control ICP. If it remained greater than 25 for 1 to 12 hours, the patients were then randomized into the surgical group of decompression or the medical group where barbiturates were then permitted. The primary endpoint for this study was the 6-month extended Glasgow outcome score. And to refresh, this is an 8-point scale. This is important in terms of its middle scoring. At the extremes, we have death and upper good recovery. But what is important to be aware of is the difference between upper severe disability, where patients are independent at home for at least 8 hours, compared to lower severe disability when patients are dependent on others for care. The study randomized 408 patients from 52 centers in 20 countries, and we're very grateful to the investigators internationally, and many of these patients were recruited from the Asian part of the planet, and we're very grateful to our colleagues in Asia for their contribution to recruitment for this trial. 206 were allocated to craniectomy, 202 to barbiturates. The treatments and interventions were similar preoperatively. The results showed between the surgical group on the top line and the medical group on the bottom line, the 8 categories of the extended Glasgow outcome score. and you can see this major difference in mortality with a marked reduction in mortality in the surgical group between 25 and 30% compared to mortality in the medical group approaching 50%. So a major reduction in mortality, but of those patients in the surgical group compared to the medical group, there was a higher rate of vegetative state, lower severe disability and upper severe disability, but similar levels of recovery in the better outcome categories. We pre-specified collapsed that into 3 categories: mortality, vegetative and lower severe versus upper severe. And you can see at 6 months, again, the big difference in mortality, the higher rate of vegetative state and lower severe disability, but also a higher rate of upper severe disability or better, not significant. But by the time you get to 12 months, you do see improvement in the surgical patients, such that 45% of them were upper severe disability or better, compared to 32% of the medical group. How can we actually translate this into information to help us manage our patients? What Rescue ICP showed is if you have 100 patients and you treat them with a decompressive craniectomy compared to medical treatment, you will save 22 more lives. What's important is the level of disability and the outcome of these 22 more survivors. And they break down into a category of 5 in the vegetative state category, 4 in the lower severe disability category, but 13 in the upper severe disability category, independent, at home or better. So there are approaching 60% of patients who are at least at home with a degree of independence. That's what the results showed and how the data can be perhaps used, but I think it's helpful at this stage to now reflect on what Rescue ICP means and how we can use this data to help inform practice. Rescue ICP provides Class 1 evidence that this operation is life-saving. There is no doubt that decompressive craniectomy saves life. We felt very strongly that these are the most severely injured patients with the poorest prognosis, and this was our justification for the pre-specified dichotomization at the level of upper severe disability, equivalent to independence at home. And at 6 months, we saw, in addition to this reduced mortality, more patients were likely to be dependent. But at 12 months, 45% of the patients were at least independent at home, compared to 32% in the medical group. Why do some of the surgical patients do well and other of the surgical patients remain dependent? We all know that CT scan is a fantastic imaging modality for imaging hematomas and other lesions that we know need surgery early. But what CT is not so good at is missing important prognosis-defining pathology, which will not be improved with decompressive craniectomy. Decompressing hemispheres with raised intracranial pressure in the presence of a severe brainstem injury is probably not in the best interests. And often these brainstem injuries are not seen on a CT scan, but you will see them on an MRI scan. And the same applies to other pathologies, including diffuse, very severe diffuse axonal injury. This operation is not a panacea. Both DECRA and Rescue ICP have provided information that aids discussion with families. But what we have also learned is that we should probably move away from saying that a study is positive or negative, and also avoid using terms which can be regarded as loaded, such as favorable outcome or unfavorable outcome, because favorable outcome for one family patient may be unfavorable for another, and vice versa. Families and patients will accept different degrees of disability. So we feel it is now better to state that the best evidence that we have available is that DECRA has showed us that early decompression before other more advanced treatment options does not improve mortality or outcome. as a rescue intervention when most other interventions have failed. Decompressive craniectomy reduces mortality, and the data we have available shows that about 40% of these survivors are dependent, but about 60% are independent at home or better, and it takes a long time, over a year, for the full benefit of decompressive craniectomy to declare itself. Martin Smith, who chaired the Data Monitoring and Safety Committee for Rescue ICP, has said that decisions to recommend decompressive craniectomy must always be made not only in the context of its clinical indication, but after consideration of an individual's patient's preferences and quality of life expectations. Now we have Rescue ICP published. We have an update of the Cochrane review, where we note, this is Juan Sequilo, that the operation was controversial, but we do now have some data. But they talking about future research is still needed in terms of looking at the best quality of life, some of the issues in relating to timing and surgical technique. So there is further more to be done. Also, recent data has shown the effect of decompressive craniectomy, and there's a number of studies now which actually shows that quality of life is good in these patients further out, around 10 years after rehabilitation from traumatic brain injury. And I think we need to be conscious of moving away from these classical 6-month outcome appointments to the future. I'd now like to focus on primary decompressive craniectomy for acute subdural hematomas. So this, remember, is the operation where we have the acute subdural, we evacuate it. The option is to leave the bone flap out, a decompressive craniectomy, or to replace the bone flap. The fundamental research question is, does decompressive craniectomy, bone flap out, lead to better functional outcomes compared to craniotomy, bone flap replaced, for adult head injured patients undergoing evacuation of an acute subdural hematoma? In order to answer that question, we sought to randomize 440 patients to either placing the bone flap back or leaving it out after craniotomy for acute subdural. This trial, Rescue Acute Subdural Trial, was the follow-on trial from Rescue ICP. It included adult head injured patients who were undergoing surgery for acute subdural hematomas. It was a major logistical exercise in that the patient was randomized in the middle of the operation. So following evacuation of the hematoma, the patient was then randomized during the surgery into the bone flap replaced or the bone flap left out, except if significant swelling prevented safe replacement of the bone flap. Rescue Acute Subdural, again, a major international effort, and again, we are grateful to our colleagues in Asia for their support and recruitment to Rescue Acute Subdural. This trial recruited to target. It finished recruitment. We are now have the 1-year follow-up data. The primary outcome is the 1-year Glasgow outcome, and we are analyzing the results with a view to publishing the results of the Rescue Acute Subdural trial in 2021. We have written further about decompressive craniectomy, and this review that's published in Intensive Care Medicine, the good, the bad, and the ugly. What is the good? Well, we have good evidence. There are 2 RCTs in traumatic brain injury. There are several RCTs and 1 pooled analysis. The impact is decreased mortality, with 59% of survivors at least independent at home from Rescue ICP, improved ICP control, and a reduction in intensive medical treatment, e.g. barbiturates, and associated complications. The bad, the impact is a prospect of survival with a range of disability, an association of high risk of complications relating to the initial procedure and the subsequent cranioplasty. And I think what is also important to realize, and this is a really important message, is that following decompressive craniectomy, patients will require both early and ongoing rehabilitation. And therefore, I think we need to be conscious that the results do not necessarily translate to environments where there is limited rehabilitation. The ugly, we cannot predict the likely disability in individual survivors. MRI scans are helpful, but we need to do more work to predict who is going to do well and who is not going to do so well. We need to look better at quality of life and more detailed outcome measures. There is a variation in the uptake of decompressive craniectomy, and that's something we need to look at. And there's a risk of clinicians recommending it based on their own opinions, and shared decision-making is essential. I would like to acknowledge the patients and their families who've participated in the rescue trials, all the collaborating clinicians and research staff from the UK, Europe, beyond. All the collaborating clinicians and research staff are listed in the appendix in the New England Journal of Medicine. The tremendous work undertaken by the committees to run these trials, the Trial Steering Committee and its independent chair, Professor Bell, and the Safety Committee, Data Monitoring and Ethics, run by Mr. Donald Shaw, and subsequently Dr. Martin Smith. Finally, there are a number of charities and organizations that helped start these studies, but we are very grateful to the UK government and the National Health Service for funding these trials. The National Institute for Health Research is the research part of the UK National Health Service and has been very supportive in funding rescue and a number of other trials through the Royal College of Surgeons. That is my email address and also our website. Myself and Professor Khan are very much involved in research in low and middle income countries through our global neurotrauma network, globalneurotrauma.com. Very pleased to announce that we would be happy to tweet about your webinars and conferences further. Thank you very much for the invitation, and I'd be delighted to answer questions.
Thank you very much, Hutch, for a very, very important and interesting talk. Just a few points I would like to highlight is that the importance of discussion with the family is paramount importance to know what they would like. Also, as you said, the timing is very, very important because if you are late, the results would not be the same. And as you pointed out, it has to be a large flap if you're going to do a decompressive craniectomy. I think people would like to also think about the study which we plan to do regarding Hinge Craniotomy, whether in the lower and middle income countries, this would be an option, whether you leave it in or out or you leave it loose. But the most important point which is missing in our countries, in lower and middle income countries, and where things go wrong is the rehabilitation, which is the most important part in this whole process. Thank you very much. So maybe questions, I suppose?
Yes, I think there may be so many questions to Professor Hatchison. First of all, I'd like to thank Professor Hatchison for this wonderful lecture at the ACNS webinar. And we had a lot of learning today from him. The first question I would like to ask to Professor Hatchison is about the idea of Cystinostomy. What are his comments regarding this controversial technique?
So Cystinostomy is an operation that has been advocated by certain people, possibly as an adjunct to decompression or as a primary procedure. The ethos behind the operation is by undertaking opening of the basal cisterns, then you will help drainage of CSF and lower pressure. Personally, it's an interesting concept, but the evidence behind it is very poor, and I'm concerned about this operation in terms of how it's being done, the indications for it, and what it hasn't undergone is a rigorous evaluation of the results and analysis of outcome of these patients. I think there's a concern that it may be done in patients where it's possible to do without severe brain swelling, and these patients may not need it. And there's a concern that in patients with very severe brain swelling, and actually accessing the basal cisterns could be quite harmful to the patient. So we always have an open mind about evidence, but at the moment, for me, this operation should only be undertaken as part of a very rigorous research trial that is governed by an ethics committee with very clear consent. So in summary, if we're going to do this, it should be done as part of a randomized trial and not on an ad hoc basis.
Thank you very much. Another controversial is this the thing of hypothermia in brain injury. There are several results for and against. What is your opinion regarding this intervention?
So that's a really good question. Hypothermia is one of those treatments that again has gone in and out of fashion. The two clinical trials, Eurotherm and Polar, showed no evidence of benefit from hypothermia and potential harm in those patients randomized to hypothermia compared to normothermia. My personal view, having treated many patients with hypothermia, is that it is very effective in some patients at helping control intracranial pressure. It is a good treatment for intracranial pressure. The problem is the side effects. And with hypothermia, particularly when you're going below 35 degrees, that we're beginning to see problems with blood clotting and problems with infection, particularly pulmonary infection in hypothermia patients. And it may be why these patients are doing poorly in the trials. So if you are going to use hypothermia, you need to use it with great caution and monitor very carefully and treat appropriately the complications.
Thank you very much. As my dear co-host Liu Boon Seng would like to comment.
Thank you, Raja. Thank you, Professor Hatchison. I wish to ask a professor regarding the concept of primary insult, because we do have a patient who deteriorate even with the normal ICP and also with good control of secondary insult. And usually we sudden onset of malignant brain edema, in some cases acute infarction. May I ask, Professor, in your opinion, do you think that primary insult actually is a precursor of a cascade of events that we still do not understand, especially in terms of diffuse vascular and diffuse axonal injury? My second question is regarding ICP, because in your trial, you do quite early decompression, because we do experience certain patients, we respond good even with just ventricular drainage. And in my practice, we find that some patients will respond well, but again, depends on what are the cutoff point of the ICP after the EVD drainage. In your practice, Professor, what do you think that the upper limit of ICP that would likely responding to medical therapy rather than decompressive craniectomy? Do you take a cutoff point of 40 or 45, for example, that you think that patient should try medically first, or you will subject them for decompressive craniectomy early? Thank you, Professor.
Thank you. Really, two really good questions. So the first question was about primary insult and how the severity of that primary insult in some patients leads to secondary deterioration quite rapidly. Now, there was quite a significant proportion of patients in rescue ICP who initially presented with a Glasgow Coma score of between 13 and 15. So they were initially mild, and then there was a subsequent deterioration. And I don't think we fully understand the pathophysiology why these patients deteriorate. Clearly, the primary impact may have been more significant than we felt, but I think there is a cascade of biochemical abnormalities, but possibly also neurophysiological issues, perhaps in relation to subclinical seizures, cortical spreading depression, other pathologies that ensue over the following hours that cause the patient to deteriorate. But that's a really good point. Initially, the primary insult is not severe, and yet the patient still deteriorates. The second question, again, really, really important issue. So rescue ICP, we tried to be sensible in terms of the timing of decompressive craniectomy. If you do it too early, you could argue, well, you didn't need to do that. You could have managed the patient medically or with an external drain. If you do it too late, it's the patient, it's gone. The brain is swollen, the the prognosis is defined as bad. So rescue ICP, we set the threshold of 25 millimeters of mercury, but you had a period of 1 to 12 hours to control it. So the answer to your question, if the ICP is 45, then I think it's very reasonable to give medical intervention, and particularly an EVD, a trial, a rapid trial to see if you can bring the ICP down. But if you are not succeeding within that time frame of 1 to 12 hours, depending on how severe that ICP insult is, then we would go for a decompression. So that really important points. Thank you.
Well, one of the main drawbacks of conducting trials in places where head injuries are prominent is the lack of ICP monitoring. So as Professor Sarvade used to say that studies should be tapered to the regional availability of resources. So how can you extrapolate these results in actual?
So absolutely fundamental. We know that 80% of head injuries occurring in low and middle income countries. So rescue ICP does not address that issue in these environments, and we need to remember that. So therefore we need to design investigations, treatment and rehabilitation strategies that are applicable and appropriate. And myself and Professor Khan and our colleagues are working through the NIHR Global Neurotrauma Research Group to try and develop appropriate investigations and strategies. And examples of this include, in terms of investigation, the use of a handheld infrascanner to detect blood clots where CT is not available, the use of ultrasound to measure the optic nerve sheath diameter as a surrogate measure of raised intracranial pressure as opposed to an ICP monitor, to look at operations that may be better, and Professor Khan has already mentioned hinge craniotomy, where you would leave the bone flap in but floating, and that means you do not have to underdo a cranioplasty. But what is absolutely fundamental is rehabilitation, and we're trying to look at new initiatives where we're actually trying to educate family members into traumatic brain injury and get family members involved in patient rehabilitation in areas where this is very difficult. So there's still a lot to be done, but the point you make are absolutely fundamental in terms of improving outcome in other countries. Thank you.
Thank you very much for this exciting lecture. I think it's time, and we'll go back to our chair for his concluding remarks.
Yes, thank you very much, Professor Hatchison. These last few points which you added, this group which has been put together by Professor Hatchison and funded by NHR, doing a tremendous job to see how brain trauma can be helped in ways and means to use the local resources, especially as you mentioned, the study on the infrascanner to find the blood clots, and then to talk to family members to start rehabilitation for the patients and the optic nerve sheath diameters. I think these are things which are moving forward. I think this will benefit tremendously in looking at head trauma. But I think the more important thing is also that we need to, in the lower and middle income countries, need to start collecting data. We need to be able to focus on that. I think this is where we are losing out. Once we start collecting data, we can share the data with our European and American colleagues and from Japan and other advanced places and China, so that we are able to collaborate together in a much bigger way. I think data collection from the lower and middle income countries is of paramount importance.
Yeah,
thank you.
That's absolutely right. And we do have some plans for a new registry of traumatic brain injury. Maybe we've got a study coming out called the GENOS study, which looks at the outcome across the world, and be very happy to contribute to webinars in the future if that was helpful to update in terms of these other studies that myself and Professor Khan are involved in.
Thank you very much. Our best wishes for the new coming study, GENOS Spine, which has been which is called for recruitment. Our center was one of the biggest recruitment center for the original Geno study. We are looking forward to the
Okay,
results.
so we look forward to presenting the results of GENOS, and as I said, we'd be very happy to contribute that. David Clark has the first version of the manuscript of the GENOS,
Right.
the head injury outcome study, so we'll be circulating that to everybody soon. All right.
So thank you very much to Professor Peter Hatchison and Professor Tariq Khan for this wonderful session. And we are really indebted to you for giving us such beautiful insights into the nuances of treating traumatic brain injuries. With that, we would go on to our second chair, Professor Shubin.
Thank you very much.
Bye-bye to Professor Hatchison and Professor
I
Khan.
apologize, I'm not staying, but as I said, we're going to watch the Duke of Edinburgh's funeral. So you take care, everybody. Wish everybody a good afternoon and a good evening. Thank you.
Okay.
Thank you, Professor.
Hello, Raja. So now the next speaker is Professor Zhao Bing from Renqi Hospital. Renqi Hospital is also a very famous, they have a very famous neurosurgical center, and Renqi Hospital was also a registered training center for ACNS. And Professor Zhao Bing is a very talented neurosurgeon. He is also a hybrid neurosurgeon, both doing the open surgery and the interventional treatment. Today, his topic is intravascular recanalization of non-acute vertebral basilar artery occlusion. This is a very challenging work. Let's welcome Professor Zhao Bing.
Thank you, the professors Xu introduced our hospital and me. I would like to introduce our experience. Share, okay. As we know, vertebral basilar occlusion is very challenging because there will be high mortality, morbidity for the acute ischemic stroke. We try to share our experience for the endovascular recanalization for the chronic symptomatic vertebral basilar occlusion. And so I would like to introduce my hospitals in Shanghai associated with Shanghai Jiao Tong University. This our hospital was founded in 1844. There are 170, more than 70 years history. We have 4 campuses in Shanghai. So this is ischemic stroke is widely fatal occlusion disease influence our life experience. There are high prevalence of the 1 in 6 people will have a stroke. There will be 6 million people lives lost each year. There we also know that in China, this is the first reason of the mortality. So we have even though we have many treatments, we can use medication and stenting and CA for the stenting or bypass. We can do treat ischemic or chronic ischemic stroke. So there more than five trials to confirm stent mechanical thrombectomy for the acute ischemic stroke. If in the limited times we can for 0.5 hours we can try intravenous thrombosis to confirm, to get the benefits for the patient. But now we know if after 6 or 8 hours, or then with the 6 hours between the 24 hours, we also can try to use mechanical thrombectomy for the ischemic stroke. but the time is still limited for the lot of patients if there will be a delayed treatment before after the onset ischemic stroke. So many patients will lost the entrance of the treatment in the accurately. But how to treat the chronic ischemic stroke? But there's, as we most imaging modality can be used in the clinical practice, like CTA and MRA, we can find or can detect the many patients with asymptomatic with carotid arteries or intracranial artery occlusion, just like the first pictures we can see. This is right intercarotid artery occlusion, like this here, or the another we can see is intracranial artery occlusions. Just like DSA, we can confirm the MC occlusion. There will, but we can see some patients without symptomatic, but only present with disease, but some patient with the symptomatic. But most studies focused with intracranial stenosis. We know symptomatic individuals, the prevalence ICAS has been established around 4 to 13%. It's I think it's most prevalent in the Asian patients. But we can see symptomatic ICAS range from 20 to 53%, depending in the its different populations. But it's most popular in the Asian patients, like in China's. There will, if the patient presented with ICAS, they still have high risk of ischemic stroke. Almost 2 years, about 25 to 30% will have. We know it's very famous studies focus on the chronic carotid or anti-circulation intracranial artery occlusion. We know 10% of TIS and 15 to 25 ischemic stroke occurred. There is studies for the bypass for the chronic carotid artery occlusions. From the tables, we can see 2 years follow-ups. There will be 20%, more than 20% of the ischemic stroke. With new images can be used in the clinical practice, like high-resolution vessel wall imagings. We can evaluate the intracranial artery occlusions. Just this patients presented with MC occlusions from this segment, it's M1 segment. There is we use vessel wall imaging. We can see this is high intensities. This we can know the length of the occluded arteries. We also can see the CT perfusion. We can confirm there is insufficiency of the blood circulations. Just this one patient, we can see that digital angiography, we find this MC occlusion, M1 segment. Use the visual wall images, we can see this is totally occluded. There is the high intensity from here to there. There is it's limited to the 1 centimeters. This is another patient presented with carotid arteries, like the location is clinoid exclusion of the carotid segment. We can use visual wall image. We can see this is totally occluded. But we all confirm that is distal artery is the vessel wall is possible good. So we can try to think about the treatment options for this patient. How to treat, how to use the endovascular treatment for this limited short occlusion. We know this almost treatment for the bypass surgeries. We often used to treat Maya disease and ischemic stroke, like atherosclerosis caused by the occlusion. It's always used to try to coordinate carotid artery occlusion and MC occlusion. We can use bypass for the anterior circulation occlusion. But even though we have the negative results for the bypass surgery for the ischemic stroke, but we also in the selected patients have benefit for the bypass. Just these patients, we can do one bypass and two bypass for this patient. We also use scan. These are people we published in 2013. We talk about that. We try to use stenting angioplasty for the symptomatic chronically occluded carotid arteries. These people we try to also try to do prospective carotid single center studies. We published here to confirm. We try to use endovascular recanalization for the carotid artery occlusion. How to use to the angioplasty stenting for the occluded intracranial like MC or the IC occluded occlusions. And here we often use the micro wire centralized to pass through the occluded lesion. We try to use depending according the basic principles elements of the MC. This direction and this we try to use details. This is a micro wire. We followed by the micro catheters here to the distal arteries. Before we do treat everything, so we try to use micro catheter to injection to confirm this is distal artery is good, it's safe. There is no preparation from our procedures. Then we try to use a long micro catheter to extend to put the normal distal arteries. We try to use balloon. It's like gateways. We dilation of the occluded arteries from here, and then we try to. We also before we put a stent, we confirm that this dilated artery is better than before. And then we put a stent, deployed a stent. We always one span, just like we treated ICAS studies. The final immediate angiography to confirm the distal artery is pinned. We have the good circulation from the proximal arteries. We can supply the cerebral areas. For example, we can how to treat the vertebral basilar arteries. The procedure similar like the anti-circulation procedures. Before we treat, we try to input the guideline, guide catheters placed at the V2 segment of the vertebral artery. We an injection, we confirm the totally occluded from the basilar arteries and almost nearly to the vertebral segment V4. We also try to use microcatheters to injection to confirm the patent of the distal basilar arteries. And then we try to balloon to dilate the occluded arteries. So we also use guide catheters injection to confirm this circulation is better than before. The final immediate angiography to confirm the artery is open again. Even though there is almost this the residual stenosis, but most patients we try to follow up and to continue. If there is re-occluded or the is a severe stenosis, we try to use a balloon in the second time. This is how to treat indications for the symptomatic vertebral basilar artery occlusions. Before we do the treatment, we also talk about this is indications or is symptomatic syndrome. Talk about this is evidence for the symptomatic vertebral occlusion. Is there is no cancers. There is no good trial to confirm the benefits of our treatments. We also we will try to check the list, the detailed clinical and imaging evaluation. We try even we do the medication first, and then repeated TIA or ischemic stroke. We will talk about look for the second opinion for the treatments. Most importantly, we use new imaging vessel wall imaging to evaluate the vessel morphologies and why cause the artery occluded. We often use the vessel wall imaging to make sure this is the plaque fissures or the dissections or the everything. We will possible reasons for this occluded arteries. We also try to perform before the treatment. We will do angiography to evaluate the cerebral flow to confirm this hydamic insufficiency. How we treat, how to use the image to detail information before the treatment. We often use MRI to detect the ischemia areas. We will check this is the syndrome is associated with occluded arteries. We also use MR. The first MR is the uninvasive. We perform the arteries morphology we can, and then we also ultrasound or the CT angiography. Like here, we also use the CTP and perfusion to confirm this is it's a hemodynamic insufficiency of the areas. We also use angiography to use the Willis skull-based circulation to find the collateral circulation before the anterior posterior. For the patients with vertebral basilar artery, there is collateral circulation. We often use from the anterior to posteriors. This is just for this is angiography we can find the PCOM to find some patients with if the patient with totally occluded the vertebral basilar artery, we try to put the catheter to the internal carotid to find the posterior circulation way to find where you can see this from anterior to posterior collateral circulation. For this patient, there is no collateral circulation, but we form the vertebral injection with the occluded of the distal of the vertebral artery. Yeah, this is the patient we try to use visual wall imaging from here. Is V4 segment of the vertebral arteries. These are high intensities. We can see this the distal artery forms occluded artery. There is a pendant of the basilar artery, the basilar tip arteries. This is we use restrictions from here. This is the left vertebral artery is the basilar artery. The basilar artery is patent. It's now is limited to the and short occluded segment of the vertebral artery. We try to use microcaster, micro Y to pass through these occlusions to the distal arteries. If they also use a CT perfusion, we can find that the occipital lobe and the cerebellar areas is endemic insufficient. We try to for the several examples of our patient. This is the patient 59 patient male presented with DZ and working unstable for 3 days. They have the histories of hypertension, smoking. The MRI showed that there are many small infection from the cerebellar and brainstem, the peduncle areas. The angiography, we find that is the both vertebral arteries occluded. So we use the G2V balloons to dilate the occluded arteries, and then in the microcasters, after those dilation use balloons, we put a one stent. We can see the radial stenosis after treatment, but the patient clinical syndromes and there is syndrome obviously improved. And after the 3 months later, we use a balloon dilated the stenosis. We can see this very good recanalization using treatment. The second patient, this 60 years old male presented with progressive disease for 2 years. The progressive disease, vomiting, weakness, and working unstable, deficit before the admission, has a history of the 40 years of smoking. We also use MR to find that cerebral areas ischemia. And in this MR, MRE, we show that the totally occluded of the basilar arteries. The patient, before we do treat, we talk about we can use medicine for the treatment and follow up. But several months later, the patient syndrome became worse. The muscle strength decreased, the proximal muscle strength, distal muscle strength is 0 degrees. This is anterior circulations injections. We also find that the both carotid artery, the 2 stenoses from the anterior circulation. There we didn't find that there's no collateral circulation from the anterior circulation. there's no PCOM we can see. This is the right vertebral injection. We find that the severe stenosis of the vertebral arteries, the right side. The left side, we can see this is a V2 segment is totally occluded. And then similar procedures, we use microcaster to pass through the occluded arteries and interchange the micro wire to use just is I think it is the patient we treated about 5 years ago. We try to put a stent first, and then we can see the stenosis. We try to use balloon and dilation again. The patient with the polypolar syndrome of the patient improved, the dizziness disappeared after the treatment. The patient can walk independently 1 year after treatment. The second patient is the 63 years old male presented with progressive disease for 2 days. Biopsy cancer positive in right side. MR we can show there's the proton and the cerebellar many ischemic areas. The total occlusion is right in the right vertebral arteries. This is we confirm that the third segment of the left vertebral arteries. We try to we also check the anterior circulation, but fortunately we can see from this is the posterior communicating arteries is obvious from anteriors to posteriors. We can see this is blood flow retracted to the best artery. We to check this is right left vertebral artery injection. This is internal carotid artery injection. We can see this flow is retracted to the basilar artery. The more than third, I think is the distal of the basilar artery is good. It almost to the occluded is here. We also use the similar procedures. We put microcatheter in the distal arteries to confirm the distal artery is good, it's normal. We can try to treat. And then we put the stent the first. It's here. The stills occluded. We then use balloons to dilate this stent. Also, the final immediate angiography to confirm the good painting of the basilar artery. The syndrome completely disappeared after stenting. The final patient with the basilar artery occlusions given here, it's total. I think is nearly a total occluded. It's the basilar artery. The angiography to confirm it here. This distal artery is good. We try to use the this. We can see the short occluded basilar arteries nearly totally occluded. We can use angioplasty and stenting, and then use a similar procedure like we should mention above. It's to use balloon dilated after the angioplasties. We can see good painting and use there's the reduced stenosis. We try to bigger a balloon to dilate it again. The immediate angiography to see here is good. Get a good patency of the best arteries. This is the final angiography to confirm here. So we try to make a conclusion for the chronic syndrome symptomatic vertebral basilateral occlusions. Before we treat, the detailed clinical information we will acquire, and we often use vessel wall imaging to evaluate vessel morphology and the possible reason of occluded arteries, like plaque features or dissections. Most important, we before the treat, we try to know the patient still with the hemodynamic insufficiencies before the treat. But there we can see this is right treatment portion for this patient, but there is no consensus for the treatment. We still no evidence to support our treatment. There, I think treatment of the vertebral basilar occlusion is still very challenging. We try to use the stat pre-samples to evaluate the patient before the treat. The patient first, the patient with symptom, and there is hytemic insufficiencies according to the CT perfusion. It is anatomy is we can see the occluded. Before we will make confirm the distal anatomy is good. The distal artery is good. We can still there is still a chance to treat. This is the patient still with resistance. If the patient with dependence, there is MIS. I think is less than 3 grader. The time that we will be chronically almost patient we will to the 3 weeks we can try it, but I think it's vertebral basilateral occlusion. There will be a high morbidity and mortality in the acute ischemic stroke. But how to treat the chronic symptomatic vertebral basilar artery? I think we will try to multiple. I think it's a good teamwork for the individual patients. Artillery treatment for all of the patients. If we try to careful evaluation before the treatment, we will. I think they will talk very careful discussion with their family and the patient. But there is still challenging. We try to do the treat to helpful to patients. We hope for this the treatment can benefit for all of these patients with symptomatic occlusion. Thank you for your attention.
Okay, thank you, Professor Chao Ping. Very difficult work and a very dangerous treatment. So would you tell us how is a long-term follow-up result for your patients?
After the treatment, we often use 6 months of the follow-up for the angiography to confirm. After treatment, 3 months, we often tell the patient to receive MRE and to detect to confirm there's still potency after the treatment.
You mean MRA?
Yeah, MRE for the 3 months, angiography for the 6 months. We still have no long-term follow-up. I think the longest of the follow-up of patients only 5 years. There's still good potency for the occluded patient, but there are still patient syndrome disappeared after our treatment.
Okay, nice talk, nice presentation. Thank you.
Thank
Any
you.
questions
We have it open.
from
with
audience?
Dr. Liu Bun Seng, would you like to ask something?
Yeah, thank you, Raja. Thank you, Professor, for a very interesting discussion. I wish to find out from Professor because in the angio was a cow. So do you actually use your image from the MRI to decide your direction of your catheter when you try to open up the occluded vessel? My second question is there any in terms of imaging technology where we can do intraluminal view to see whether such cases can be angioplasty can be performed in those cases? Thank you, Professor.
Yeah, that you means that we talk about this detailed information for the clinical imaging evaluation for the occluded arteries. Use angiography or MR angiography, we couldn't tell the possible reason for the occluded artery. We try to use vessel wall imaging so we can from the high burden of the plaque. Atherosclerosis causes the occlusion with long time. But still in the young patients, we also find that this is dissections. If the young patient with dissections, occlusions, we often use medication and follow up. But with some patients, the occluded arteries with medication, that still has spontaneous occurred of dissection, and the arteries is total, it's spontaneous open again. It's very interesting for the young patients. It's very challenging before we treat. We often try to do the endovascular treatment of all of the older patients with have the atherosclerosis occluded reasons. For the most patients who have the long history of the hypertension, diabetes, or the smoking histories, there are many high risk factors for the stroke. We will try to treat.
I think there are no more questions. We can go back to our chair, Professor Shubin, for his concluding remarks.
Okay, thank you for your patience, and I think Professor Zhao Bing's work is very creative, and it's a very, I think because more and more neurosurgeons participate to the interventional treatment. It's in some very selected cases, you can achieve the great result from the interventional treatment for this revascularization of the non-acute basilar artery, or sometimes ICA occlusion. So I want to introduce his work to the ACNS members. Thank you.
Thank you. Thank you very much. It was indeed very challenging and wonderful work shown by Professor Chao Ping. So in that case, we'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers for today, Professor Peter Hatchison and Professor Chao Ping, for coming here, and the chairs, Professor Shubin and Professor Tariq Khan, for chairing the sessions. Both the sessions were very exciting. We had a lot of learning today. Thank Dr. Liu Bun Seng for being my co-host for today, and all the audiences and special faculties who joined us. So until we meet on next Wednesday, it is bye-bye from all of us. Thank you very much for joining.